So medical legal aspects of endophthalmitis, okay? So basically, we've conducted inquiry into a lot of, so what happens if you have an endoph, or what happens when you have a medical legal problem? So when disaster strikes, do not panic. That's the most important thing, because all the mistakes, because you may panic and you may hide the endoph, you may tell some patient something wrong. So first of all, if something has happened, if there's a death on table, if the patient has died, so just don't panic, relax, sit back, and then think what is to be done. Take your priorities. That what is your first priority? Patient care and then administrative matters. So these are two different things. Dr. Hitesh Bhai has already talked about it. You have to divide the two, and you have to see to it that these two run parallelly. Talk to the patients and relatives. This is exactly what has been going on for the last 1 hour. Be patient, tell the truth, be there. You cannot run away, isolate the patient. So if you have a patient of endophthalmitis and the other patients are good, separate the patient, otherwise there will be a lot of panic, and start treatment immediately. So what about the administrative and the medico-legal matters? Are inform the, so if you have, the rule is that if you have one endophthalmitis and it's a case where there's nothing wrong and there may be a patient factor, you found out what has happened, it was a complicated surgery, patient was diabetic, everybody else was fine, then there is no need. But if you have a cluster endoph, if you have more than two, it is mandatory that you inform the health authorities. So it's extremely important. After you have informed, you have to submit a daily progress report on the patients and the measures taken. This is also very important. You have to call the experts. So the expert basically in ophthalmology should be your friend. Somebody who's a shoulder to cry on, somebody who's an expert. So suppose if you are a cataract surgeon and if you have an endoph, then you have to call a vitreoretinal surgeon. So ophthalmology, microbiology for a second opinion, moral support, and as a neutral expert. So you need a second opinion. If you have taken a second opinion, it's very, very important with respect to the medico-legal aspect. And this happened to me and I have taken an expert opinion. Okay, shut down the theater till the cause is found and rectify if you have a cluster. And before the OT closes, send samples of solutions, IOLs with batch numbers, and therefore documentation is very necessary. When you have used something, you should not discard it. The same, and so you, like in our OT, we have registers where batch number of everything from syringes to solutions, like starting from betadine, xylocaine, paracaine, everything is maintained and it is mandatory. You have to send swabs from the theater to the microbiologist, find the cause and rectify it, okay? So the cause, if you track back, it could be the patient, the surgeon, or the theater. Possible sources could be airborne, not very likely. Solutions and medications we've seen, say for example, we've seen Avastin causing endoph, okay? Or somewhere where we've seen viscoelastic causing TAS. It could be tissues, okay? So the patient who has a mucocele, a dacryocystitis has been missed. Objects and materials. So, once we were packing drapes for a camp and I sit down and personally pack them because we do around 2000 surgeries. And once we had packed around 200 drapes, somehow or the other we had to open and we found that some of them were not completely sealed. So if there was a problem with the objects and the materials that you are using, not autoclaved, ETO'd, not sanitized, sterilized. So there have been cases where the phaco tubings have not been autoclaved properly. So objects and materials and their autoclaving is important. Respiratory origin, there have been instances where if in cases of infection, or organisms have been traced to the respiratory tract of certain OT personnel. Surface origin, like from the skin. Air conditioning systems are very, very important. So cleaning, maintaining documentation is important. So solutions and medication is irrigation solutions. There were times when, you need to check the ringer before it is used. It has to be checked in light in such a way that you can see floating particles. And there have been documentation of fungi, ointments. I know of people who have called up crying saying, yeah, OT staff has used an expired lens and the box was given to the patient and then there is no escape from it. Instrument disinfectants, like, there was a diagram shown of Chittel's forceps. They are no longer to be used because they are no longer, you cannot use anything with Chittel's forceps. Your hands have to be sterile. You have to use gloves while using any instruments. skin antiseptics. We have betadine solutions, 500 ml bottle, and I saw somebody pressing the swab on the bottle. So the mouth is always not clean, and I told them it has to be poured. And I see people who open syringes like this on the trolley, and I know a lovely video from Arvind where they have seen how many particles fall down. So although you have to open the cover outside and the syringe has to be pulled by the person who is washed up. So small things matter. Viscoelastic intracameral drugs. I'm always scared of using different intracameral drugs with respect to asepsis. Skin of the hands, skin of the operative field, lid margins, lashes, conjunctival sac, lacrimal sac, and nasal mucosa. So there was an incident of endophthalmitis where one patient had dacryocystitis, sac syringing was done, the same cannula was used. I will be documenting it later. Objects and materials, we know all these objects and materials like tonometers, magnets, drapes, mask, gown, rubber gloves, bulbs, droppers, glass syringes, needles, bottles. Nothing should be reused. Phaco tubings have been the cause of endorphs recently, and because they are used multiple times, you do not have that many sets, multiple cluster endorphs have occurred. IOLs, like I told you, expired IOLs, sutures. Okay, so these are all objects and materials. So what are the vital clues? Now, when you are going back and thinking that, okay, now I have an infection, what do you do? So number of patients affected, whether it is random, same OT table, conventional or phaco, re-examine, go back and assess all the patients. So what went wrong? I'll just give you an example that there were 59 patients, 31 got affected. There was one patient with a sac infection. So this was in a rural area. Somebody operated and only one cannula was used for sac syringing. And that patient was infected and everybody got infected. Another case, a gynac OT was used. And so, of course, only a patient with phaco, whether it was the phaco or whether it was a gynac OT, so either of the two. Again, the phaco tubing in this case where only the phaco patients were operated. So the phaco tubings, if they are not clean. Now in the COVID period when our operation theatres were shut because we were COVID centers and our residents were doing COVID duties, routine ophthalmic OT was shut. But the whole time, maybe it was 3 months or 6 months, our phaco tubing with or without surgery were autoclaved and cleaned every day. So if you are not using a phaco and if you're not using a tubing, and if it is not being cleansed properly with the residual material, they are very good culture materials. So we used to have reactions in some patients, and we found out that was the first phaco and there was some residual water. The minute we started emptying some water during the first phaco and changing the person who cleaned the phaco, we stopped having a reaction. So you have to think, you have to assess, you have to evaluate. So every time we write that this was the first phaco tubing used, first case, second case. So you have to document everything in order to evaluate. Another case where common prostate surgery was done and E. coli was found. So theatres have to be dedicated. I know of very big hospitals in Mumbai where somebody had called me up and asked me that we don't have a dedicated theatre. What do we do? So I said, please do not join the hospital, even if they are paying you crores, because you will be in trouble and then they don't save you. Pseudomonas was found because the OT was not prepared and not sterilized. 11 patients operated, 6 affected. The affected patients were complicated surgeries. 20 patients operated, Citrobacter was found. Now this patient, I had gone to investigate, and the soap case, the same organism was found in the soap case. People were washing hands after a bathroom and washing up with the same soap. No bar soap should be used, and it should be only only liquid soap. So it's extremely important that, because the soap cases are never clean and all that. So even if you have dispensers, there was a dispenser in my room which was not cleaned, and I told the sister to throw it off, because dispensers, the boxes of dispensers also have to be cleaned, and you have to remember that the pinkies have to be cleaned. So these are very, very important. So in one case, Pseudomonas was found and the same pair of gloves were used. So from one patient, it was transmitted. Okay, so methyl cellulose was, so what do you get? You get an infected sac, non-sterile OT, unclean phaco tubes, unsterile instruments, infected soap case, intraocular viscoelastic was a problem. So these are simple causes. They are definitely rectifiable. So you can prevent such disorders by correcting the patient factors, theatre and personnel, hygiene, lacrimal sac. I think this has all been discussed by Satanshu Mathur sir. So all this hygiene, lacrimal sac, lids, dedicated, isolated OT fumigation, all this. So this is the same as what he discussed. So I won't repeat it again. So all these things, are very, very, very important and imperative. So he's already discussed this. Personnel he has discussed. So basically, prevention is better than cure. Due diligence, proper precautions can prevent disorders. So it's very important. And what we notice in the consumer cases that come to us are that there is a lot of negligence, in the sense, I'm not saying negligence, but no consent is taken, or a person who was diabetic was given steroids, and then the patient didn't have anything, but because they were given 60 milligram steroids, and the patient was admitted 1 month later for some medical cause, but they are blaming the ophthalmologist, saying that steroid was given. So basically, you have to be very, very careful. And you have to document everything. If there's a complication, you cannot run away from it. You have to tell the patient. So it's extremely important. So I think that you have to be careful. You have to prevent everything, which is extremely important. Thank you so much. Thank you, IRSI, and Pooja for this wonderful seminar.
Thank you, ma'am. Thank you so much. This was really, really valuable because, these are the small points that we don't realize, but which are very, very important, like changing the soap bar, or, the dispensing soap that needs to be altered frequently. And, it's very, very important.
So
Thank
for
you so much.
example, like I can use only Dettol. I cannot use the Sani scrub because I'm allergic. So they always ask me, should we get a refill pack? So I tell them, don't get the refill pack because the bottle will not be. It's expensive, but take a small quantity bottle and discard it. So small things have to be looked into, and it's a way of life. You have to get used to. So like we do have in sleepers and out sleepers, and I have to correct. And you have to be very careful with what your anesthetists are doing too. They will sit with the mask down. You are sitting inside. They will go out without slippers, out clothes. They will not change, go out, eat, come back. So you have to have control over everybody who's inside the theater with you, not only yourself.
Ma'am, I wish we had these teachings and this chapter or subject in our MS Ophthal training period as well. Because we don't realize, like, we sometimes be like, okay, this is normal, but it's not. Even our teachers don't teach us the correct way, probably because even they don't know the proper medical legal
So in
aspect
fact,
of it.
let me tell you, Pooja, the first lecture I take as an orientation for my residents is infection control. Like we start from saying that when you take the vision, see, I know some years back that when there is florid conjunctivitis in Mumbai, like while taking vision, the whole post-op had conjunctivitis. So you have to learn to tell them from the beginning and teaching vision that if the patient's eye is red, so sometimes an optometrist doesn't differentiate from a red eye from subconjunctivitis. But we tell them that if their eye is red, you have to come and show the patient. The patient, in our case, goes to a separate building. That is the eye bank, which is now used as a septic ward. We don't even allow the patient. We do not allow any maggot patient to enter our facility. We are a general hospital, tertiary care, so we do have patients with maggots, but no maggots are allowed to be treated or operated even in a septic theater. They go to the ENT/OT and we go there and operate, but the patient is not allowed to enter our facility at all. So small points which are very important.